What I'm going to share with you today is a project that we're currently undertaking at CSHISC Group, and which has actually had quite a protracted birth, or it has, I think I'm still in labour at the moment because the facility doesn't open until December, January. God, we're in December. And but this innovation has actually been something that was quite significant for us, and the planning phase has actually been in place over 3 years. What I'm going to talk to you a little bit, and I'll try and be as quick as I can to ensure that you have an opportunity to ask questions, because many of you will say, well, what on earth are you doing there? But we'll just talk a little bit about how the group went about the planning process, what we did around the building, the consultations that occurred in the community, and also the outcomes of those. So this is a little bit different to what the other presentations are around today, but this is specifically about the way that CSHISC as an aged care provider is actually seeking to meet the needs of our growing population. During the planning and development stage, we had, the intention was there to build a full extra services facility. We currently run 2 extra services facilities, and for those of you that are not familiar with that term in aged care, there is an implication and an imperative that the residents that live there, that they actually receive maybe additional choices that we are obliged to facilitate access to and provide an additional range of services than may be required in all of residential aged care. But the thing that was quite critical to the group about this was that these things needed to have, the services that were coming into this and going to be facilitated from this facility needed to have a demonstrable benefit to the residents. It wasn't just a nice idea that we plucked out of the hair and that we thought would actually present the facility better. This was a concentrated effort to actually be saying, what is it that people are needing, what is it that would make a benefit to them, and what can we do about that? So we needed to identify the space that might be available for these. We went through an extensive planning consultation around what sort of relevant services that we might be able to include, but also critically that they had to have an identified benefit. When we were actually looking at the service specifications about what is it that this may be in this new facility, just to give you a bit of background, the facility at the moment is 34 beds. It's a low care facility, and it's going to be 140 high and low care. It's on the campus of the Murdoch University, and we actually front out over the Oval, but it's also surrounded by a large retirement village. So in an essence, it's a retirement environment. And so importantly for us, when we were building this facility, it was probably going to have the services may have a wider group than just the 140 that were going to be from our facility. Potentially we would be looking to provide the service into the village as well. Critically, it needed to improve health outcomes, and there was a bit of work that we did with our own staff, with our own extended stakeholders around what that might mean. We needed to be able to provide the services, whatever it was, to the frailest of clients, and in a sense you can understand where we might have been being led as we were going through this process. We needed to be able to attract a relevant provider, so whomever it is that was going to be assisting us in providing this service, it needed to be relevant to the client group. And because we did not want to be, and as it's turned out, a dental service, we didn't want to be dentists, and so in a sense it was actually providing the environment for the service to be provided in, and also one that was not currently available in most residential care environments, because at the end of the day it is important for us to be able to keep our facilities full. This is a business, and it is important for us to be able to manage that in a viable way in the best interests of our clients. The consultation was quite broad. We looked across the industry needs, and this was both the health but also the aged care industry, and so we looked quite broadly at what it is that was out there, what people were doing, what innovations were effective, those that may not have been effective, and in a sense had an understanding of what it is that was possible in those sorts of environments, what it was that may be required, what it was that our residents wanted. So in searching and surveying the residents in our extended community, it was what were the sorts of things that would make a difference to people if they actually had access to them in the service. Another thing that's probably important about probably most of aged care do try to engage community. They do try to encourage an environment where there is a lot of in-reach from community, and in an aged environment that is quite difficult. But this was another of the considerations. How is it that we can actually create a much more of a normal environment in a residential care environment that is more about the way that they would conduct their lives if they weren't living in a congregate environment? So in a sense, it was also what innovations might we be able to bring into the facility. In going with the staff surveys and the staff focus groups that we conducted, there were three things that were identified as of issue to staff around the way that they support the residents. The first one was that it is quite difficult to be able to support the residents for off-site appointments. And in high care, that is a bigger burden to be carried by the provider. In low care, the families are responsible. And also just to consider the provider. So for example, somebody goes out to the dentist, or if they go out for a specialist appointment, the capacity for those environments to actually cope with people who are quite frail, who may have behaviours, and their environment may not necessarily allow for a frail client to actually be examined easily, to actually receive the treatment. The thing that was outstanding was a lot of people can get access to a dentist coming into the facility, although in our environment that has its challenges, but many of them don't have access to get the treatment. So the assessment part was good, but the treatment part was very, very poor. And so in a sense, that was actually access to the service. And so I understand that the photographs that were not shown around what may or may not occur in residential aged care are likely a result of those issues, not being able to get access to the appropriate care. And through all of the consultations, there was a lot of people, because we opened the doors, and so when you open the doors, lots comes to you. And interestingly, some of the things that came to us were, well, you know, dementia is a really big concern. Now, yes, we are having a dementia-specific environment and a secure environment. Also, the Parkinson's group are a significant group of people that have got high needs as their condition deteriorates. And so we looked quite closely at those diseases and common medical problems that actually lead people, and also some uncommon ones that actually lead people down a pathway of considerable frailty towards the end of their lives. But the one that stood out the most was the need for dental services, and so the next step came along. Then we went back and looked at our own residents, and I think that I've got the stats here right, but in looking at our own residents, I've got the me and the moo, if you have a quick look at the slide, but the me is one of our facilities, Melville, the other is Murdoch, and it was an interesting observation to understand that 57% of people in one of our facilities actually go to the free clinic. This is a practice that was established. However, they may wait, and since they've been in residential care, they go annually, but prior to that they may have waited 5 years between appointments. And at the other facility it's about 80%, and the other facility's got a much smaller number, and it's about our efforts to actually concentrate and encourage and work with the families to actually allow those appointments to be facilitated. About 24% of people anyway saw their own dentist at Melville, and but about 19% have no regular dentist services. And we will talk about the standards shortly, but it is imperative that providers actually facilitate appropriate care. The difficulty in actioning that is that you are negotiating with families and sometimes with individuals, and their choices are often that they don't choose to pursue that. So it's very important for us to have robust plans in place and strategies to ensure that they do get access to this, and sometimes they absolutely fall through the gap. those that actually, and the other thing I think was interesting when we did the survey, and this was done, we've been doing this regularly in our own facilities, that they noticed that there was an increasing number of people that are actually have got their own teeth, and so it well supported all of the projections of the plan that have been put in place. Since the implementation of the oral health plan and also the implementation of the standards, assessments and reviews have been part of normal business in our facility, and but I would not like to put our hands up and say that we are doing it fantastically or that we are of the best and highest standard. It's the start that we needed, and we've now got somewhere to go from.